Alright, we'll be looking at geriatric patients in this special population. Special patient population. Changes associated with aging, physiological aspects of aging, and age-related assessment and treatment modifications for the major common geriatric diseases and or emergencies, especially those concerning cardiac diseases, respiratory, neurological, endocrine, Alzheimer's disease, dementia, and fluid resuscitation in the elderly. Patients with special challenges are recognizing and reporting abuse and neglect, healthcare implications of abuse, neglect, homelessness, poverty, healthcare implications of bariatric, technology dependent, hospice, terminally ill, tracheostomy care dysfunction, home care, sensory deficient, and loss and developmental disability. Looking at trauma and some care things we'll find with trauma patients. Alright, geriatric assessment and treatment of disease, injury in someone 65 years old. Older persons will continue to become a larger population percentage, and the aging body can mask serious medical conditions just due to different diseases and processes that may be going on. Some economic impact of aging. Older people may not seek medical assistance because of concern over cost and cost of and cost of prescriptions may cost to skip days of medication or reduce the dose. Independent and dependent living. Small percentage of older people live in nursing homes. Many live independently. Some are primary caregivers for their parents. They may fear that if you take them away from the hospital or take them to the hospital, they will never see home again. But most healthy older adults strive to live independently. Some do not have family and friends to assist them and are self-dependent. Patients isolated from outside social events are susceptible to self-abuse or alcohol or medication abuse. Stress of caring for a chronically ill person can become overwhelming, and dependent living has many different levels of assistance. A lot of it's based on the needs of the person and possibly on restrictions placed on the person. Advanced directives of end-of-life care. Mentally competent adults have the right to consent and be declined care. So, like your DNR or DNAR orders, physician orders for life-sustaining treatment. Some of these create specific orders to be followed at the end of life. Healthcare proxy is a named surrogate. to make decisions regarding the patient's health in the event they are incapacitated and unable to make decisions. Hospice services provide homes for the terminally ill. Communication. As far as communicating with these patients, you will need to ask open-ended questions as possible so that you can get them to communicate back to you. Sometimes you may have to use closing requests to clarify a point and avoid being overly familiar with the patient. Avoid being judgmental. Gain the patient's confidence, and after interviewing the patient, ask family members or caregivers to clarify. So, responding to nursing homes and skilled nursing facilities. Nursing homes and skilled care facilities are common locations. Before providing transport, ask the patient's chief complaint and admit diagnosis. Compare the patient's present condition with conditions before onset of symptoms. Obtain transfer records. And infection control needs to be a high priority with these patients because they usually do pass a lot of diseases amongst each other. Many causes of death in older people are heart disease, followed by cancer, chronic low respiratory disease, Alzheimer's, stroke, diabetes, trauma, and pneumonia. Physiology of older people makes them more vulnerable than younger people, and acute illness and trauma are more likely to involve the organ systems beyond those initially involved. So here's some leading causes of death. All right, as people get older, the AEMT changes. So it does not mean that a person will experience disease. Common stereotypes about older persons are usually far from the truth. Body undergoes several changes. Bone nerves begin to deteriorate. Reaction time decreases. Blood pressure increases. Ability to maintain normal body temperature decreases. And muscles less flexible and strength decline. Changes in the respiratory system include respiratory capacity reduces. Alveoli become enlarged. Elasticity decreases. Receptors that monitor changes in oxygen and CO2 slow. And changes in the distribution of blood flow within the lungs can result in the decline in partial pressure of oxygen in the arterial blood. So, slow reaction time to hypoxia or hypocapnia. Kyphosis may limit lung volume and maximal inspiratory pressure. Decrease size and strength of respiratory muscles. Increased likelihood of airway obstruction from either secretions and food particles. Chronic low respiratory diseases and pneumonia are the top causes of geriatric death. One cause of death is infection with pneumococcus bacteria, and another cause of respiratory distress is pulmonary embolism. And changes in the cardiovascular system as the cardiac output declines. Decreased ability to increase the heart rate, increased cardiac contraction strength, and constrict blood vessels. And dysrhythmias may develop also. Many are at risk for atherosclerosis. Atherosclerosis increases risk of stroke, heart disease, hypertension, and bowel infarction. Older people are also at increased risk for aneurysm. So AAA is one of the most rapidly fatal conditions. Changes in the nervous system reflected in neurological exams, short-term memory impairment, slow reflex times, performance of most sense organs declines, and sense of body position impaired. And hearing the inner changes make hearing high frequency sounds difficult. Prebustus is progressive hearing loss, physiologically changes make speech production that is loud enough, clear, and where spaced difficult. Taste buds decrease in number. Patient with diminished taste may not be able to discern fresh food from spoiled food. Touch, sense of touch decreases from loss of specialized nerve fibers. Alterations in pain perception can result in the patient not seeking medical attention. The smell may last to diminish. Factors such as upper respiratory infections can affect smell. Disorders affecting mental status, delirium, inability to focus, think logically, and maintain attention. So assess for hypoxia, hypovolemia, hypothermia, hypoglycemia with all mental status. Dementia is the slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. It's generally irreversible and develops over a period of years. Signs and symptoms take months to years to become apparent. So none synonyms with delirium. It's not close with delirium. Neurodegenerative diseases such as Alzheimer's disease is caused by the death of neurons of the brain. It begins gradually, and symptoms may present as confusion, changes in personality or judgment, and extreme difficulty with daily activities. Parkinson's disease involves nerve cells in the motor area of the brain caused by insufficient formation and action of dopamine. It may be present in dyskinesia, dementia, depression, autonomic dysfunction, and postural instability. Depression and suicide. Depression is not part of the normal agent, but rather a medical disease, treatable with medication and therapy. It can mimic effects of many other medical problems, extreme and persistent. Treatment of severe depression consists of physiological counseling, medication, and/or a combination of both. Changes in the musculoskeletal systems, vascular diseases, decrease in bone mass in men and women. Changes in physical abilities can affect confidence and mobility, and degenerative changes in cartilage contributes to the arthritis. So kyphosis produces flexion at the neck and the anterior curling of the spine. Osteoporosis is characterized by decreased bone mass, resulting in reduction in bone strength and greater susceptibility to fracture. Osteoarthritis, progressive disease of joints that destroy cartilage, promotes formation of bone spurs, and results in joint stiffness. Changes in gastrointestinal system, decreased number of taste buds, and changes in olfactory receptors may diminish taste and smell. Dental loss contributes to nutritional and digestive problems. Hydrochloric acid in the stomach decreasing, and changes in gastric motility. Function of small and large bowel changes little. Activity of enzyme systems concerned with detoxification of drugs and alcohol decline. The possible cause of abdominal pain and shock is GI bleeding. Bowel obstructions occur frequently, and risk of dehydration as a result of diarrhea. Risk of food poisoning also. So loss of function in the nephron system. Acute illness is often accompanied by derangement in fluid and electrolyte balance. Kidneys respond slowly to sodium deficiency and are less able to excrete a large sodium load. So lower glomerular filtration rate. Susceptible to hypokalemia, urinary incontinence can result in irritation, skin breakdown, and UTI. In severe cases of urinary retention, patients may have acute or chronic renal failure. Changes in the endocrine system, hormone levels of production changes. Patients with diabetes are at increased risk of hypoglycemia. Delirium may be the only indication. Hyperosmolar hypoglycemic syndrome occurs with type 2 diabetes. Physical changes are a primary result of excessive dehydration and hypoglycemia. Thyroid abnormalities increase, so atrophy is more likely to be induced in an overactive thyroid gland. Changes in the immune system. Every function of the immune system is affected. Older persons manifest infections differently. Some signs and symptoms of shock include fever, respiratory distress, increased pulse rate, generalized weakness, and hypotension. Joint changes in skin, collagen elastin decreases. Bruising is more common. Healing process takes longer due to decreased blood flow to capillaries. Epidermal cells develop more slowly. And high risk of secondary infection after skin break. Sebaceous gland produce less oil, making skin drier. Pressure ulcers, thinning of the subcutaneous fat makes pressure ulcers are more common in older, bedridden patients. Decubitus ulcers form when a person lies in the same position for too long, exacerbated by fecal and urinary incontinence. Classified in 4 stages, if untreated, they can cause substantial infection and potentially make the patient septic. Homeostatic and other changes, progressive loss of homeostasis, infections that would ordinarily produce high fever may produce only a low grade or no fever. Aggressive treatment of this moderate hypoglycemia may produce hypoglycemia. Toxicology, several pathophysiological changes cause older people to become susceptible to toxicity. Decreased liver function, polypharmacy among geriatric patients is very common. So if you do suspect non-compliance, check prescription dates and the number of pills available in the bottle. So in your assessment, the safety, general condition of the home will provide important information. Nature of their illness may be difficult to determine. People who may have an autoimmune status or dementia. Ask specifically what is different today to distinguish acute versus chronic problems. In your primary survey, do not make any assumptions about an older patient's level of consciousness. Never assume that an autoimmune status is normal. You may have to rely on a family member or caregiver to determine the baseline level of consciousness. Treat airway and breathing issues as soon as possible. Poor perfusion is a serious issue. And patient assessment more complicated and more problems can exist. Priority patients include poor general impression, airway and breathing problems, all level of consciousness, shock, any severe pain, and uncontrolled bleeding. So consider paramedic rendezvous and provide immediate treatment and transport. G's calls on you to recognize that the patient is a geriatric patient. E stands for environmental assessment, M stands for medical assessment, S stands for social assessment. So obtain information pamphlets about some of the agencies for older people in your area. In your history taking, patient communication is always essential. Play detective and determine actual problem. And a few well-chosen questions can provide a great deal of information. So here's some cardiovascular questions you can ask. Also some respiratory questions. Some neurological questions that you can ask. Some gastrointestinal questions. And some clinical questions you can ask. So a medication history should include all medications, not just prescription drugs. Assess compliance by checking the fill dates on medication bottles and find out who fills the pill box and when it is normal. Dizziness or weakness, obtaining accurate information can be difficult. Check for PMS and all extremities, fever, pain, use your OPQRST, and consider the current weather. In your secondary assessment, do not underestimate the pain sensation of older patients. Protect the patient's modesty at all times. Keep the patient warm and maintain body temperature. Keep heart rate should be in normal range, but however it may be lower due to medications such as beta blockers. Respiratory rate should be the same range as in younger adults. Auscultate breast sounds. Appropriate SpO2 data. Histoprobe might help confirm accuracy of poor perfusion and determine the patient's normal blood pressure. And your reassessment conditions may deteriorate quickly. Repeat, reassess everything you've done so far. Recheck your interventions. Identify and treat changes in condition. Document all assessments. All right, interventions including positioning, oxygenation, administration of glucose, and physiological support. A lot of patients maintain a position of comfort. Assist ventilation is needed. Be mindful of monitoring level of consciousness in COPD patients. They may be retaining CO2 more than usual, and listen, respond, and provide reassurance. In your full resuscitation, this can be challenging. Modest amount of blood loss can quickly result in shock. Monitor breath sounds frequently and use fluid sparingly. All right, with your shortness of breath, obtain accurate patient medical history. Patients should not be overwhelmed with questions. Find out whether the patient's history has a history of respiratory problems. Give them supplemental O2. And talk about medication taken prior to your arrival. Asthma common among older adults, so you coexist, and you might want to use your beta-adrenergic agents for asthma. So regular epinephrine can be indicated for a life-threatening asthma exacerbation. So you try to use your beta-2 drugs. Steer away from epinephrine due to the cardiovascular signs. Pneumonia is very common, especially those in skilled nursing facilities, just due to the bacterial nature of it and its spreading. So they may benefit from CPAP. Make sure you bolus on these patients. Always check the temperature also. A PE check for swelling. 10 minutes to your lower leg. Handle the leg gently and monitor the patient's respiratory changes. So this is going to be supportive help, but reassess frequently. Syncope, life-threatening problem until proven otherwise. I always think of syncope has cardiac in nature until proven otherwise. Chest pain treated, APQRC mnemonic. Describe how exactly you feel, and follow your chest pain protocol. Your mind is quiet symptoms not present in older patients. So you might have dyspnea, joint weakness, syncope, confusion. You need to assess their cardiac nature also on all these patients. Heart failure increase with age causes of associated risk factors. Prevention is aimed at lifestyle changes. So pay close attention to the position in which the patient is found. Also ask the patient how they are laying at night, if they're able to lay supine or if they're having to sleep elevated. Okay, do the treatments. Closely monitor your fluids. Most of these patients just need a saline lock. Consider CPAP and potential for use of anticoagulant therapy. All right, dysrhythmias generally result in age-related changes. AFib increases the risk of stroke and heart failure. And bradycardia is more common in older people. Some medications can cause excessive bradycardia and persistent bradycardia treated with a pacemaker. Hypertension. Control hypertension helps prevent strokes and EMIs. Hypertensive emergencies require a controlled decline in blood pressure that often cannot be achieved in the field. Aneurysms, life-threatening aneurysms, can develop in the brain, chest, or abdomen. Preventative measure aims to control risk factors associated with hypertension and atherosclerotic diseases. Examine the chest and abdomen carefully. Early recognition, assessment, stabilization, and rapid transport are essential. Traumatic aortic disruption. Inside the wall, the artery becomes torn and allows blood to collect between the arterial wall layers. Get a blood pressure reading of both arms, and systolic pressure difference of 15 or higher suggests a thoracic dissection. These patients need to be on an OR table. All right, delirium, mnemonic, drugs and toxins. Emotional, psychiatric electrolyte imbalance, low PaO2 infection, intentional stool urine. Seizures, undernutrition and underhydration, metabolism, and subdural hematomas. Use airway adjuncts if patient is unable to maintain his or her own airway. Obtain IV access to use a fluid resuscitation route if needed. Stroke is the leading cause of death in older people. Some risk factors are listed here and some signs and symptoms. So a lot of people are using a fast mnemonic with the strokes also, so don't forget about it. So we need to recognize it early. Know the capabilities of the facilities around in your area, your region. because these are daily changing and what these folks can do for strokes. TIAs is temporary disturbance of blood supply to the brain, so it's treated as though he or she is having a stroke, because usually 9 out of 10 times the big stroke is coming. Neuropathy is a disorder of the nerves. Here's some of the motor nerves and signs and symptoms: sensory nerves and autonomic nerves. Autoimmune status is a symptom, not a disease. Management is complicated. Consider neurological causes and endocrine changes. Determine the onset of the symptoms. And find out what's normal for the patient and why it has acutely changed. Vitamin C and D mnemonic. Your neurologic and endocrine emergencies. Diabetic disorders management complicated for older adults. There are increased risk of hypoglycemia, so confusion about medication doses or usage, inadequate or irregular dietary intake, inability to recognize the warning signs, and blunted warning signs. All right, assessment of hypoglycemia. Hypoglycemia is complicated by changes, so you need to check it every 15 minutes. HHS, it's more common to DKA, causes an infection. Airway management should be a top priority. Spinal motion restrictions should be also for all unresponsive patients found laying down. Treat for shock as indicated, large bore IV access. Patients with history of heart failure and are renal insufficiency give full sparingly. Glucose levels less than 70, and the patient symptomatic administer supplemental dextrose either oral or intravenously. Thyroid disorders, abnormalities increase with aging. AFib is more likely to be induced by the overactive thyroid gland. Patients with hypothyroidism or hypothyroidism are likely to require supplemental oxygen. Abdominal pain, constipation is common with older adults, so investigate. So I always ask about the intake and the outtake. History of acute versus chronic pain may help with your assessment. OPQRST mnemonic. If you think it's a AAA, treat the patient for shock if evident. Gastrointestinal bleed decreases peristalsis, increases likelihood that irritant substances will cause gastric lining or cause damage to it. Pathological processes include ulcers and varices. And bleeding from esophagus is the most commonly associated with varices and alcohol abuse. Bleeding from stomach may produce rare to darker coffee ground emesis, bright red to stool. On correction, bright red blood in the stool comes from the large intestines or rectum and may be caused by diverticulitis. Upper GI hemorrhage, bleeding occurs from the esophagus, stomach, and denum. So recognize the use of NSAIDs or alcohol can cause bleeding from the stomach lining or ulcers. Lower GI hemorrhage, bleeding from the colon and or rectum should never simply be attributed to hemorrhoids. Assessment should begin with identifying the risk factors such as the history of previous lower GI bleeding. Symptoms and signs suggestive of other conditions. Severe lower GI bleeding requires immediate transport, and more important to assess the severity of the bleeding than the cause. Treatment should be focused on recognition and management of hypovolemic shock as well as rapid transport. Patient may be on blood thinner medication. All right, nausea, vomiting, diarrhea could be contribute to something other than the GI tract. It may be cardiac in nature. So look for your clues and possible causes. Bowel obstruction is caused by cancer, impact the stool, or sigmoid bullosis. Small bowel obstruction and secondary gallstones increase substantially with age, and the intestines are at risk for obstruction and adhesion. Biliary disease is signs and symptoms of jaundice, fever, right upper quadrant pain, vomiting, and nausea. Although the disease causes fever, response may be repressed in older patients. Pain cessation may be altered. and be cautious in administering opiates. Peptic ulcer disease, older patients are more likely to have stomach and or duodenal ulcers. Main symptom is dyspepsia. UTIs usually develop the lower urinary tract, so patients will report painful urination, frequent urges to urinate, and difficulty urinating. So if they do have a dwelling catheter, look at the output and see if it's colored dark or how it looks. Renal failure results from decrease in rate of filtration through glomeruli. Chronic renal failure may require lifelong hemodialysis or kidney transplantation. So if a patient does miss dialysis treatment, the situation can become an ALS emergency. So monitor your vital signs. Do not obtain blood pressure readings on the same arm that the fistula is in. Monitor breast sounds carefully and closely. So transport to a facility that has hemodialysis capabilities. Non-compliance medication can cause an emergency. Pharmacokinetics, decreasing kidney function and GI absorption, increased susceptibility to toxicity. May be influenced by diet, smoking, and alcohol consumption. So doses for older people need to be reduced. Drug and alcohol abuse is often a response to life-changing events. Prevalence of alcohol and drug misuse among older people is also attributable to the multiplicity of medication and the physiological changes of aging. So it can be difficult to recognize. Severe risk to several factors place an older patient at higher risk for trauma. So reduced cardiac reserve, decreased respiratory function, impaired renal activity, and an ineffective vasoconstriction may result in unsuccessful recovery. Most trauma cases involve falls or motor vehicle crashes. Falls are associated with a higher incidence of anxiety and depression, a loss of confidence, and post-fall syndrome. So carefully get your history, and home safety assessments may reduce fall incidents. Overall physical condition may decrease the body's ability to compensate for the effects of injury. So older patients have reduced stroke volume along with potential dysrhythmias, decreased respiratory function, and a decrease in chest wall compliance. Higher risk of cerebral bleeding following hemadomas can go unnoticed because the blood has a void to fill before it can produce pressure in the skull. Female patients may have decreased bone mass and strength from osteoporosis. Compression fractures of the spine more likely to occur, and burns substantial risk of morbidity and mortality. Monitor hydration status by assessing current vital signs, mucous membranes, and urinary output. Ability to recognize fluctuations in temperature becomes delayed, so you always keep your temperature in the ambulance high And trauma can result from abuse. So when you're seeing signs up, think of your safety first, take BSI, consider them a patient, and determine the need for additional resources or specialized resources. Addressing the life threats, think conservatively. Recommended to transfer older trauma patients to a trauma center regardless of the severity of the obvious injuries just due to the overall factor of their health. So general pressure is important. Use your AFP and GCS to determine mental status. Leave dentures in place as long as they will fit. In an unresponsive patient, open the airway with modified jaw thrust maneuver. Complete your respiratory assessment and keep suction readily available. And manage any external bleeding immediately. Always be suspicious of internal bleeding. In your history taken, look for family members or bystanders who may be able to provide information about the patient's history. Call for a medical alert activation. Find out if it's an inactivity alarm or distress alarm. Do not lower your index of suspicion when vital signs do not change as anticipated based on suspected injuries. So their changes in vital signs may be delayed for some reason. So, from a fall, how long they be on the ground? Their neighbors, if you have to, see when the last time they seen. Determine why it caused and consider medical control. Consider if a medical condition caused the fall. It could exacerbate or be exacerbated by injury. In your secondary assessment, head trauma may be life-threatening. Breathing may be impaired. So check your breath sounds. Look for evidence of pacemakers or defibrillators. Decreased muscle size in the abdomen may mask abdominal trauma. Look for bruising, assess the pulse, blood pressure, and skin size. Capillary refill is unreliable, and determine if the patient's blood pressure is normal for him. In your reassessment, geriatric patients have a higher likelihood of decompensating after trauma. So your management of geriatric trauma, broken bones are common and should be splinted in a manner appropriate to the injury. So do not force a patient with pronounced joint flexion or kyphosis into a normal anatomic position. So you may have to pad those boys. Splintings such as vacuum mattress may be a good choice for immobilization. So use caution when using certain IV catheters, as they may cause bruising also. Take steps to preserve temperature. For patients do not do well with a traction splint. For a femur fracture, immobilize the cervical spine before transporting. Provide psychological support and document assessment, treatment, and reassessment and any changes in the patient's status. So report abuse and neglect. Those are mandated. Neglect is the failure to provide needed care, services, and supervision. Prevalence of elder abuse is not fully known for several reasons. Physical and emotional signs of abuse are often overlooked and are inaccurately identified. Patients with sensory deficit, senility, and other forms of autoimmune status may not be able to report abuse. Inspect the ears for indications of twisting, pulling, and pinching. Investigate multiple bruises in various states of healing by questioning the patient and reviewing the patient's ADL. Burns are a common form of abuse, and to try to determine whether the patient appears undernourished or has been unable to gain weight in the current environment. Check for signs of neglect. Any trauma to the genitals or rectum as evidence of sexual abuse in any patient. So assessment and management of elder abuse. Just transport these patients to the hospital, have them thoroughly evaluated. Caregiver does not allow the patient to answer questions. Repeated visits to the ED or clinic. Any history of being accident-prone, soft tissue injuries, psychosomatic issues, chronic pain, self-destructive behavior, depression or lack of energy, and a history of substance or sexual abuse. So if the patient is in a stable condition but the situation is unsafe, see if the patient will accept transportation to the hospital. If they don't, you may have to get adult protective services involved. So if the situation is immediately unsafe, notify law enforcement personnel and remain with the patient only if the scene remains safe to do so. It's not your responsibility to prove that the abuse occurred, only to report your findings occur and report your call. That's the end of this chapter. Physical abuse or as follows: human bite, pressure bruises caused by a human hand, inflicted bruises that may be on the buttocks, lower back, genitals, upper inner thighs, cheeks, and earlobes.